So this is the February MEC Minute, and our topic this month is going to be medication safety. So what's on the agenda for today? Well, we're going to talk about medication safety and why this is the MEC Minute topic of the month, and why in February is there medication or patient safety medication stand down for all MEC members. And I'll explain that rationale in a moment and give you kind of the case review of what prompted this stand down. So we're also going to talk about reasons for medication errors. We're going to talk about the 5 rights of safe medication administration. I think it's something you already know, but we're going to review it anyway. Also, want to review MEC's medication cross-check clinical standard. It's something that's been in place for years, and I want to make sure everybody understands it and make sure everybody understands the need to do it in order to keep patients safe. And then we've drafted some volunteers to do a quick video of demonstration of safe medication administration using our medication cross-list or cross-check. And you may recognize some of these providers. So just a recent case. Recently, one of our EMS providers, an experienced crew, had an elderly patient requiring intubation. They determined that they were going to follow the DSI procedure, and they were going to administer ketamine as the procedure calls for. They utilized ResponseSoft, so kudos to them. They took the phones out of the pocket. They used ResponseSoft to calculate a dose, and they determined the patient needed 180 milligrams of ketamine, which with the concentration of 50 milligrams per ml was determined to be 3.6 milliliters of this medication at that concentration. This is the volume that was determined by the ResponseSoft app. The crew did administer 3.6 milliliters of ketamine. However, they used the more highly concentrated form of 100 milligrams per ml and effectively double dosed the patient. So the patient got, instead of 180 milligrams of ketamine, the patient got 360 milligrams of ketamine. They could have used this higher dose, but they would have to first dilute the 100 per ml concentration 50-50 with saline down to a concentration of 50 milligrams per ml. If you look at the vial on the right, it clearly states that you have to dilute it before IV use. So they could have easily taken a saline flush, 10 cc saline flush, forced out 5 cc's and drawn up 5 cc's of the ketamine. That would have given them the more appropriate concentration of 50 milligrams per ml. Then it could have given 3.6 milliliters of that concentration. But the patient inadvertently got 360 milligrams of ketamine. So, and to the crew's credit, they promptly reported the error. And in our atmosphere of culture of safety, we reviewed the process and we talked about how can we avoid this in the future. So how did this happen? Well, this is a high-stress situation. The patient was in trouble. The patient needed an artificial airway. The crew correctly determined that the patient needed to be intubated. They correctly identified the dose to be given, but they used the wrong concentration. In retrospect, looking at the event, there were no safeguards in place to flag the more highly concentrated medication. There was no prompt, whether it's from labeling or isolating one medication from another, one concentration from another, to prompt the crew to say, oops, I've got the wrong vial, let me get the correct vial. So there are no real engineering controls or engineering work practices in place to keep the patient safe and to prompt the crew to notice that they had the wrong concentration. And the other part is they did not follow the medication cross-check procedure, even though there was adequate time. Yes, the patient needed an urgent airway, but they had the 60 seconds it takes to do a cross-check. And there were an adequate number of providers on scene to complete the cross-check. So it was an engine company and the medic crew with, I believe, 5 providers on scene. So there was enough staffing available to take the extra time to correctly identify the correct dose and concentration of medication. So you may think, okay, this happened. What real liability is for me? Well, this is just an illustrative case out of Newport, Kentucky, right across the river from Cincinnati. And it's a fairly recent case and has to do with a patient being given the wrong medication. The EMS treated a female with a head injury. She developed nausea and requested Zofran. So the patient had some medical awareness because she personally asked for Zofran. EMS felt that was reasonable thing to do. They drew up medication, but it erroneously administered intravenous epinephrine. it's unclear how they made the error distinguishing Zofran from epinephrine, but either way, patient got IV epinephrine. The patient then developed chest pain. She was treated for chest pain, apparently had some cardiac event, and has had complications since then. The patient has filed a lawsuit against the city of Newport and EMS providers, alleging negligence with failure to follow the 5 rights of medication safety, resulting in this myocardial infarction with complications. So I like to point out that they are suing and alleging negligence. So if you look at Ohio's immunity that we all have as EMS providers, and I have as an EMS physician, we have immunity from lawsuits as long as there's negligence or criminal intent. Well, that's probably why the city and the providers being sued for negligence, because negligence is exempt from the immunity. So who knows how this is going to turn out, but it would have been a whole lot better for everybody, and the providers would be probably sleeping better at night if they followed procedure and correctly administered the right medication following the correct procedures and the 5 R's of medication safety. So this is just an illustrative case why you need to take a double look at your work processes are. So what have we done as MEC EMS? So this event that I used as an illustrative case occurred about a week before we had our chiefs meeting in January, and I discussed this with the chiefs, and we've made these determinations. First off, we're going to carry 2 concentrations of midazolam and ketamine. Those are the 2 medications we have that have 2 different concentrations. And if you look at the medication errors we've had over the years, and there are not a lot of them, but we do have them, the errors are usually related to errors in medication concentration. We have 2 different concentrations for 2 different reasons. The more highly concentrated medication or form of the medication is really intended more for intramuscular and intranasal use. So if you have patients having a grand mal seizure and you want to give the patient intramuscular or intranasal midazolam, you use the more highly concentrated. If you have a behavioral emergency, a patient needs intramuscular ketamine, we're going to use the more highly concentrated. The lower concentrated version of these medications is for IO and IV administration. We're not going to dilute medications anymore, so we're not expecting the crews to take ketamine 100 milligrams per ml and do a 1-to-1 dilution. I think that's fraught with errors. I think ketamine, it's not a cheap drug, but it's not a terribly expensive drug. I think it's reasonable to carry both concentrations in the truck. And I think it's also reasonable for all our crew members to know which concentrations are for which routes of administration. The other thing that we agreed to is that each agency will identify means to flag different concentrations. So each agency has its own processes. It has its own means of storage of the medications. But we want all agencies to identify visual prompts to the providers to check the drug concentrations. It could be one concentration is stored differently than the other. Your airway kit may have the more dilute form of ketamine, and you may have the more concentrated available in another area. It could be a matter of you put some kind of a readily visible label that you have to see in order to open up the vial. So it could be a label that goes over the cap of the vial that somehow flags this as a concentration that you need to be aware of. Or we could use some type of colored plastic sleeve, whatever works for your agency. So it's not for us to determine what each agency should do, just that you need to do something to identify the different concentrations of drugs. And the last thing we all agreed to is in February, this month, we're going to have a safety stand down for all providers to review midazolam and ketamine concentrations, those work practices that we're putting in place to flag different concentrations, and for all providers to review the medication cross-check. So going on a little bit, how do we make medication errors? I think we can talk about patient safety, but we also need to have an understanding of what happens. Well, sometimes there are medication errors because there are similar medication names or spelling. If you go to the hospitals and you go into the order section of the electronic patient system, typically medications that are like sounding or have similar spelling have certain prompts to them so the provider knows that the patient is getting Phenergan and not phenytoin. So they may have certain parts of the spelling capitalized or bolded out. So you say, oh, that is, I really want the patient to get Phenergan. I don't want them to get phenytoin. Another thing that can happen is similar packaging. So here I've got pictures. The ketamine and the midazolam have similar colored caps. We have 2 bottles of ketamine that look fairly similar, different colored caps, but they look similar. One says 500 milligrams per 5 ml. That's more highly concentrated. The other says 500 milligrams per 10. Your eye may just catch the 500. In a point of a time of stress, you may go for the wrong vial, thinking it's the correct vial. Fentanyl, it's another vial. I know our fentanyl is in smaller doses, smaller units, and has the security tape around it. But I just threw in there as a potential source of error. And you could also have times where the midazolam looks like this kind of a vial today, but next week you get a new shipment in, and the vial is a different color. So you can't always go by color. You have to read the label. So we have to be aware of similar packaging or change in packaging based on what our vendor has available for the medication we order. Some of these medications can all have similar route of administration, IV, IO, IM. That can also cause some confusion, particularly when we're talking about concentrations. Sometimes the medications are all stored together. You have a cabinet or some type of a container, and it's got a vial of everything. And it's okay, how do I find what I need to find? Let's make sure that we get the right one. No medication cross-check. For us, it's a cross-check, or no 5 rights of medication administration. We just don't follow the procedure. We feel rushed or distracted, and we don't follow the procedure to verify that the medication is correct. Errors in weight estimation. That could be a big thing. We look at patients and we think they weigh 70 kilos. Are they really 70? Are they 80? Well, probably for most of our meds, there's no significant drug dosage error between 70 to 80 kilos. But if it's 70 kilos versus 110 kilos, that's a big difference. If you look at the Elijah McClain case out of Aurora, Colorado, where he was given ketamine, they actually estimated his weight to be twice what his true weight was. So for the providers on scene, it wasn't just a fact that they administered medication without doing an appropriate assessment of the patient. They totally, were off in the patient's estimated weight, and they double dosed him based upon a significant error in his weight. There can also be calculation errors. When the heat is on, when we're in a high stress situation, we may not make the correct calculation, or may try to do the calculation in our head. So that's why we've got HandTevi or ResponseSoft to do calculations for you based on patient's weight. Use the app. Make sure you get a correct calculation. Sometimes there are communication errors. Sometimes you ask for one thing and your partner thinks you said something else. So sometimes there are communication errors. I know I slur my speech. I talk fast. Sometimes others may not fully understand that. So make sure that you clearly articulate what you want and how you want to administer it. And then we also are in high stress situations. Patient is crashing on us, and we think we need to work fast. Well, even for crashing patients, we have 30 to 60 seconds to correctly identify the medication and make the correct calculations and give the patient safe, appropriate dose. Very rarely is the patient going to have a significant life-threatening event if it takes us an extra minute to correctly identify the medications they need. So in high stress situations, slow down a little bit. Like we used to be taught in ACLS, the first thing you do during cardiac arrest is slow down and check your own pulse. Get a grasp of the situation, make good determinations, and provide good patient care. The 5 rights. This should all be old news for you. Patient needs a medication. We want to make sure we give the right dose to the right patient via the correct route, at the right time with the right drug. And, sometimes we think about or forget about the correct route. I've had a couple patients over the years with anaphylaxis or allergic reactions, and instead of getting intramuscular epinephrine, they get IV epinephrine. They were not sick enough to get IV epinephrine. They end up having chest pain. They might even have transient changes on their EKG from the IV epinephrine. So right dose. Did you do the correct calculation? Did you use the correct concentration for the route that you're going to administer? Are you giving it to the right patient? Now, for you as EMS providers, you typically have one patient at a time. That shouldn't be an issue for you. But right patient could also mean patient's got an allergy and you shouldn't be giving this drug to the patient because of their allergies. The right route, like we've talked about multiple times, at the right time, and again, the right drug. So other things that you can do besides the 5 R's is again, our medication cross-check. It's kind of our version of the 5 R's. If you have questions, refer to the ResponseSoft app, call me, put that little effort in there to make sure you're doing the right thing for the patient. Again, to the crew's credit that we used as that example case, they used the ResponseSoft app to calculate the dose. So they were correct in that action. They did the right thing. We should all promote that culture of safety. We want patients to receive good care. Everybody, regardless of your level of certification, is responsible for patient safety. Everybody is responsible to speak up if you see something is unsafe. Culture of safety also includes reporting adverse events and near misses, because that's how we learn. So, with this crew that I talked about, that our response was to train and review. That's what's part of a culture of safety. People are not going to report errors if they are going to be punished. I think most of the errors are made because of process issues, not because somebody's incompetent and not because somebody's intentionally doing something to hurt the patient. And we learn from our near misses, just like you have near miss reporting if you have an event on the fire ground or while driving the vehicles. Near misses are important. We investigate, we learn. All right, here's our medication cross-check. This is right out of the protocol. It's a 2-person process. So the first part is you have provider number 1. That's the person who is caring for the patient, wants to administer the medication. They say, I med check or a safety check, cross check. The other provider says, I'm ready. The first provider says, I'm going to give the drug, the dose of the drug, how fast, and the reason. So I'm going to give Zofran 4 milligrams, IV push slowly for nausea. Provider 2 says, I agree. Any reason not to do that? Any contraindication? Provider 1 will say no contraindications. The patient's actively vomiting. They have no medication allergies. There's really no contraindication to giving Zofran. The second provider will agree. Then they're going to say how much or the volume. And the first provider say, I'm going to give 4 milligrams IV. It's 4 milligrams per ml. I'm going to give it IV slowly. It's going to show the vial to the second provider who says, I agree, I verify that is Zofran, it's not epinephrine, and go ahead and give it. And then we also talk about our red flags about, situational awareness and errors in production. So, again, rushing and poor communication is big. Trying something new under pressure, new drugs on the truck, you want to try it for the first time. Slow down a little bit. Interruptions. We all have interruptions. I deal with interruptions, almost every minute that I'm on duty in the emergency department, or we can be preoccupied or confused. Those are all things that we need to think about. And then have that collective awareness of patient safety and a culture of safety. And then, they make a comment at the bottom of our graphic, slow is smooth, smooth is fast. So sometimes just taking the time to do it right actually is faster than trying to rush it and finding out that you made a mistake and have to backtrack. So when we talk about medication safety and cross-checks, I get 2 common questions. And I'll give you my questions and my answers. The first common question about the cross-check procedures, I'm in the back of the truck with the patient by myself, my partner's driving. How do I complete the medication cross-check? Well, I think there are a couple different things you consider. First off, if you think the patient's going to need the medication while en route, do the cross-check before leaving the scene. So I'm going to, patient's got nausea, vomiting. I want to give her some Zofran once I get a nice IV established. Go through the cross-check procedure with your partner before he starts driving the truck. Another question would be, does the patient really need the medication or can it wait? If you're in the back of the truck, you're 2 minutes from the hospital, patient's getting nausea now. Do you really need to worry about giving them Zofran now, or can you wait till they get to the emergency department? And then the last thing is, if the patient just flames out, and you need to give them something quickly, then I'm okay with a little bit of deviation from protocol. You give the medication, but you explain the variance in the narrative. The patient required a dose of epinephrine en route. I was not able to perform a cross-check because my partner was driving. I administered epinephrine and could not fully follow the cross-check. You could also throw a comment in that after we arrived at the hospital, my partner verified I used the correct medication. Looked at the vial. So those are kind of my answers to the first question. I think most of the time, patient is not going to acutely deteriorate en route where you need to emergently administer a medication. I think the first two bullet points are the best ways to look at it. The second question is, I'm the only paramedic on the truck. Everyone else is an EMT. How do I complete the medication cross-check? Well, I think part of it is everyone is responsible to do their part, regardless of level of certification. Everybody's responsible for patient safety. It's correct that EMTs really cannot do much in terms of verifying the medications, in terms of indications, route of administration, and so on. However, they can assist with components of it, and particularly in terms of correct identification of the drug and the concentration. The vial says ketamine, right? If the EMT should be able to say, yes, it says ketamine, 50 milligrams per ml. So you can complete as much of the cross-check as you can with someone at the lower level of certification. I would not expect them to be able to say, yes, you're going to give it 2 cc's IV for nausea, but you can use them to say, yeah, I've got a vial of Zofran 4 milligrams per ml, right? And they can say, yeah, you do. So I think there's some things that they can help you with. Otherwise, do the best you can with the cross-check. So I mentioned that we're going to have a demonstration by some of our providers who got drafted to help. So here's the demonstration. I'll be back with a closeout after the demonstration.
So we have 2 medications, both with a blue cap. You have a patient who needs something for nausea and vomiting. You know that Zofran's got a blue cap, but which is the right one? Zofran, amiodarone. So we have different ways of making sure we give patients the correct medication at the correct time. One has to do with work habits and work practices and engineering controls, where we isolate or mark high-risk medications in such a way that it prompts you to look and say, hey, that one's different, particularly if we're talking about the same meds with 2 concentrations. But sometimes during times of stress, we just look for the blue cap. Or maybe there's been a change in pharmaceutical suppliers, and what used to be in a yellow cap is now in a blue cap. So how do we also work toward making sure we give the patient the correct medication? So that's the purpose of our medication cross-check. Are we giving the right medication to the right patient for the right reasons at the right dose? So we're going to give you a quick demo to review our medication cross-check procedure.
Medication cross-check.
Go ahead.
I want to give 4 milligrams of Zofran to relieve nausea.
You're going to give Zofran. Is there any contraindications?
No contraindications. I'm going to give 4 milligrams in 2 mLs IV, slow push over 1 minute.
4 milligrams and 2 mL, slow push. That's Zofran.
All right.
Go ahead and give it.
It's that easy. It takes, 60 seconds to go through the medication cross-check to make sure you're giving the patient the right medication at the right dose via the correct route. By doing that, you can avoid those never events where the patient receives a medication in an inappropriate way that may potentially jeopardize their health and well-being. So please follow the procedure, rehearse it with your crew members so you know how to do it. That's all, folks.
So in review, medication errors are really what we call never events. They can be avoided. Our error with the ketamine, I consider to be a never event because we had the capacity on scene to correctly identify the medication and the concentration of the medication. And these never events can be avoided by engineering controls, meaning how we label, how we store the medication. and by our work practices, which again is the medication cross-check. So these things should be kept in mind, and you should expect to talk about it as part of our stand down. We also need to promote a culture of safety, and this is not just regarding medications. Everyone is responsible for patient safety regardless of their level of certification. If the patient's on the gurney and the straps aren't on and you're starting to move the patient, somebody needs to say, stop, let's get the patient strapped in. Everybody needs to be involved with medication safety. Everybody needs to be involved with equipment checks, making sure it's operable and maintained appropriately. So everybody's responsible for that culture of safety. Nobody can opt out by saying, I'm an EMT and not a paramedic. You are responsible to the level you have certified. If something isn't right, speak up. And then finally, report errors. As part of our culture of safety, we use errors to learn from our mistakes. That's why we are doing our stand down. We learn from mistakes, we make adjustments in our process, and we may even add training and so on based on what we learn from the mistakes. So report errors. All right, that's all we've got. Hopefully you've gotten something out of this talk. If you have any questions, please feel free to send me an email at this email address. Otherwise, thank you for viewing.